It is 5:01, so we will go ahead and get started. I am Laura Crotty Alexander. I'm an associate professor of medicine at the University of California, San Diego, and staff physician and researcher at the VA San Diego here. I am the moderator for tonight's session of the ATS COVID Critical Care Training Forum. We're happy to have you all here with us today. Last week we spent some time again, reminding everybody there's a lot going on. We understand that emotions are running high. There's a lot of things going on. So we just wanted to, again, take a moment and from the healthcare professional point of view and across our societies, we all believe that Black Lives Matter and that hopefully everything going on today will lead to the change that we really need. All of our professional societies have put out some powerful statements that really cut through to the core of what we believe in as healthcare professionals, physicians, respiratory therapists, nurses, everyone on the call. We sort of have these core values, and it's been nice to see those raised in these clear ways. There have been some great protests, including from the healthcare professionals walking out and taking a knee for these lives that matter so greatly. And so we stand behind all of our fellow citizens of this country and across the world, because we do welcome a lot of international participants on this call and through the American Thoracic Society in particular. We do have a chat function here, and we do encourage people to say hello as they have been. So some people have said hello, but please say hi in the chat box and say where you are calling in from. We'd love to see the sea of people who are participating. We also have a feedback form that we just shared a link to in the chat box. Tonight, I'm excited to share with you our schedule. We are going to start off with a case presentation by Dr. Erica Lin. So she is a UCSD pulmonary critical care fellow. She did her internal medicine residency at the Mayo Clinic and med school at UAB, and now I know undergraduate studies at Duke. And that's going to be followed by Dr. Seth Kligerman, who will discuss radiographic findings in COVID. We're going to move into updates and controversies in COVID care. And we're going to end with a discussion on the known and unknown immune responses in COVID-19 that will be led by Dr. Sydney Ramirez and Dr. Josalyn Cho. I did want to let people know that last week on the 2nd, we had some great presentations on cardiac, neurologic, and kidney findings in COVID. You can find that forum along with 7 others, because this is number 9, so we've done 8 total. Those are all posted online. And you can find those recordings. We'll be posting this link to our survey multiple times during the session today. And, oh, this is blocking me. And then yes, you can just Google ATS COVID Forum. It'll take you to the webpage where all of the recordings are posted for free. And finally, before we get going, I just want to say that this COVID Critical Care Training Forum has really been put together by a lot of different people, including my co-chairs, Viren Kaul, Nirav Shah, and Sushma Kribs. We have a large working group. We have a team of internal medicine residents that help us run this. And then we have our wonderful ATS staff, Lauren Lynch, Liz Guzman, and Eileen Larson, and Rebecca Fish. I should add her in. So without further ado, we're going to go ahead and get started with Dr. Erica Lin and her case presentation for COVID. Let me launch. All right, and go ahead and take it away, Dr. Lin.
Okay, so thank you so much for the introduction. As Dr. Laura Crotty Alexander mentioned, I am a second-year PCCM fellow at UCSD. And I'm currently on COVID nights, but I am very, very much excited to be here. So I will be presenting a case of one of our COVID patients that really highlights some of the radiologic findings that can be seen in COVID-19 And this will hopefully provide some context prior to hearing from our expert discussant, Dr. Kligerman. So if we can go to the next slide, please. So we have a 69-year-old female with a history of diabetes that could be a little better controlled and high blood pressure. Her family actually brought her in to see her primary care provider because of a 1-day history of altered mental status, as well as a 2-day history of shortness of breath and dysuria. Her primary care provider obtained a point of care glucose and some basic vital signs, and ultimately referred her to the emergency department for her significant hypoxemia, as well as her hyperglycemia. And you can see that in the emergency department, she was febrile, tachycardic, and quite hypoxemic, actually requiring a non-rebreather to maintain her SpO2s in the low 90s. She was very ill, appearing in moderate distress with some tachypnea and overall work of breathing. And so while basic laboratory studies and broad imaging were obtained, she was ultimately intubated for her respiratory distress prior to transfer to the ICU. And we're just going to run through the CT chest that she has on admission. And you can see initially that she does have some ground glass opacities in this sort of subpleural peripheral distribution. And as she scrolls down, you can see that this is actually present in all 5 lobes. She has almost a crazy paving-like pattern with some septal thickening as well. And you can see in the last slide that her consolidated opacities are really more prominent in her bilateral lower lobes. The image isn't the best view to see her mediastinal lymphadenopathies, but she does have that as well, and they are likely very active. And so we did want to, poll the audience. Are these CT chest images diagnostic for COVID-19?
And so you can post your answer in the group chat, or you can just shout it out and let the ethos hear it. I think we should have told Seth that he's not allowed to vote, Dr. Kligerman. And also, while I'm thinking about it, if any questions come to mind at all during this entire forum, just go ahead and post them in the chat box. We actually have multiple experts present who will be chatting answers in real time. We can also bring these questions to the experts during the Q&A sessions that will happen after each presentation. All right, so lots of votes for A and B.
Yeah, and CT chests are not routinely used as a first-line test to diagnose COVID-19. And this is again another view of that CT chest. But she was admitted to our ICU for ARDS, secondary to COVID, with also a superimposed bacterial infection. She ended up getting tracheal aspirate on further testing that also grew out H. influenza and Klebsiella. Her initial PF ratio was between 100 to 150, so we actually categorized her as sort of a moderate ARDS. And on admission, she was also found to have DKA, likely secondary to infectious etiology and more of a pre-renal over intrinsic AKI. Now, for the sake of our presentation, I am going to speed a little through her management to provide some time for our expert discussant. But I will say that she was managed with typical ARDS management as is recommended, and that does include low tidal volume ventilation with higher PEEPs, paralysis, as well as proning. She was diuresed for conservative fluid management, about net negative 0 to 1 liter for about the first 7 to 10 days. And no specific COVID therapies were provided. And you can see that her chest x-rays were monitored during her hospitalization, although quite sparingly. We would get them about every 3 to 4 days as needed. And her chest x-ray progression does show this sort of worsening opacities bilaterally up to about her 3rd chest x-ray there, which was around days 10 to 14, prior to her showing some radiologic improvements. And similarly, she began to show some objective improvement based on her ventilator requirements around that time as well. Her ICU stay was actually quite complicated by her severe ICU delirium, which may have also impacted her mechanical ventilation duration. But she was extubated on day 17, downgraded to the medicine, and she's actually planning to discharge to the skilled nursing facility in the next 24 to 48 hours. So a good success story from our standpoint. Now, I'd like to briefly discuss the Radiologic Society of North America expert consensus statement on the CT chest findings related to COVID. And this is actually co-authored by our expert discussant, Dr. Kligerman. As you all know, most of the radiologic data initially came from China, where a lot of the extensive CT chests were performed. And when they discussed these sort of classic radiologic manifestations, they talked about these ground glass opacities, plus or minus consolidation in this peripheral posterior, as well as lower lung zone distribution. And this is similar to our patient's CT chest. They did mention that lymphadenopathy and pleural effusion have been rarely reported. Our patient in particular did have some lymphadenopathy, and we actually do have one patient with COVID who has a left pleural effusion. I do want to mention that the image finding really does depend on the timing of the image. So for example, the majority of the patients mentioned had sort of a negative CT chest during the first 2 days after symptom onset, and then started to develop ground glass opacities later on that peaked within the first week to 2, as well as having consolidation later in the course of the disease. And then we're going to bring you up to another one of our audience polls. Which one of these CT chests do you suspect are from an intubated COVID patient?
So again, feel free to type your answers in the chat box or just make sign language in the view. I don't actually know sign language, but that's okay. We have a lot of votes from C. We have all of the above. Any of them could be all of the above. A through F, A, C.
Yeah, so actually all of these CT chests are from our COVID patients that have been intubated over the past few weeks. So you can see that a lot of the radiologic manifestations can be very non-specific and can also mimic a lot of other disease processes, especially in patients who have some sort of underlying lung disease, as in patient A and D. And this was just a very humbling slide for me. You know, before handing over the microphone to Dr. Crotty Alexander as well as Dr. Kligerman, I'd just like to mention that while we do manage a significant number of COVID patients, you know, the associated CT chests we obtain are pretty rare. We tend to order them quite sparingly. We don't perform any sort of screening or routine CT chests based on March 2020 ACR recommendations. And this is for a number of reasons, including the non-specific findings, as well as unnecessary exposure to other healthcare personnel. Obviously, we do perform them when we have certain reasons. For example, if we're concerned about certain disease processes like a pulmonary embolism. And if we do tend to try to cluster our imaging studies. And I think with that, I'm going to hand the microphone back to Dr. Laura Crotty Alexander so she can introduce our expert discussant, Dr. Kligerman, and he will delve into the radiologic manifestations of COVID-19.
Awesome. Thank you so much, Dr. Lynn. I really appreciate it. I'm so glad that that patient, even though she had such a long course, that she did make it through in the end. I would like to welcome Dr. Kligerman to present to us today. We're excited to have him here with us. He did his undergraduate studies at Amherst Medical School in Chicago, radiology residency at the University of Colorado, and then a fellowship in cardiothoracic radiology at Massachusetts General Hospital before he has been recruited to UCSD as the chief of cardiothoracic imaging. And so we're so happy to have him here. He is an expert in imaging of many different types, but has become an expert in COVID-19 imaging in particular with multiple publications. So with that, I'll say take it away. But again, if anybody has any questions, please do post them in the chat box and we will make sure that they get answered.
All right, well, thank you. I hope you guys can hear me. So just when I was looking at that first multiple choice where someone says, which are these imaging findings diagnostic of COVID? First of all, there are no imaging findings diagnostic of COVID. COVID is not diagnosed. Someone is drawing on my screen. I don't know if people can see that, but anyways, there's no imaging diagnostic of COVID. COVID is not diagnosed by imaging. COVID is diagnosed by assays. Now, there are findings that we see that suggest a diagnosis, and there are some imaging findings which we're going to refer to. And I think the literature that came out of China, is very, the imaging appearances are different than what we're seeing in the United States, basically due to the fact that they were screening a large volume of the population, or at least in endemic areas. And when this was happening, they were scanning patients earlier in the disease. And I just want people to look at these images and, question is which of these patients have COVID. And here's some papers that some, authored and I've been on, and these are from various societies. One is from RSNA and the other is from the Flesh Society. And basically the concept of this is imaging doesn't make the diagnosis. In the United States, we're not using CT to diagnose patients. We're using CT to troubleshoot or to answer if there's a complication. Also highly recommended in the Fleishner Society is that, this is going to vary based on country. I know China, it's used CT pretty liberally. There's some, we have received some papers. I'm deputy editor of one of the radiology journals, and we received some papers to China. People getting 15 CTs over the course of a month or two. So a little bit more liberal use than we're seeing here. But, one thing they also don't recommend is daily radiographs in these patients, really unnecessary. Now, if there are acute changes where people are getting lines or put in, that's, of course, another issue. But, just to monitor these patients, just like monitoring anyone in the ICU, really not necessary unless there's an acute change. And again, because imaging doesn't diagnose, or kind of your guys' eyes on the patient and seeing what they're doing clinically is more important than what we see on imaging. So these, this process evolves over time. That's something that we've learned. Normal imaging can occur in early on in disease. It's actually, if you image people who are symptomatic for a few hours or a day, a large percentage will be normal. But the most common imaging findings that I'll show you how this progresses over time. So the most common imaging findings early on in disease, and I've seen a lot of COVID cases, and I haven't seen this pattern yet because we're not imaging patients that early or that liberally. But these come from a colleague of mine in New York who wrote some of the first radiology papers on this work with people in China. Is an old fellow of mine at Maryland. These are book people who are patients coming in with symptoms for a few days, less than 2 days, showing these peripheral opacities. Yeah.
Your microphone was cutting up a little bit, but it sounded like it might be improving.
Sorry, I don't
there we go.
know why that is. Let me see if I'm on the, no.
Now it sounds really good.
Sorry about that. Let me go back to, I think I stopped sharing.
Yes, but now the mic sounds perfect. So
Okay.
whatever you're doing, keep doing it.
All right. So, and again, this kind of morphology that was first discussed, these rounded peripheral opacities that are look very nodular. They're not centralobular. They're not micronodules, but these nodular patterns were kind of discussed in China. But again, I haven't yet seen a case like this. I know in New York City that they've seen some cases like this, but we're just seeing more people later on in disease. And again, just important to recognize about imaging, a negative CT does not exclude disease. This patient has symptoms for 2 days and has a completely negative CT. And then he or she is a few days later with continued symptoms demonstrating these nodular subpleural opacity, somewhat ground glass, somewhat consolidative in areas. A unilateral disease, just like in any infection, can occur, but it's just not as common. Like most viral pneumonias, usually bilateral. Absent in early disease, especially within the first week or so, lymphadenopathy, pleural effusions, cavitation, micronodules, so nodules either random, centralobular, perilymphatic. We're talking about nodules less than 5 millimeters, quite uncommon. And depth consolidation, especially lobar consolidations, are uncommon. But remember, we're seeing people who might have super infections or other conditions going on, so things can be somewhat variable. This is a patient who was a 37-year-old, is a vapor using cigarettes. This is an AI algorithm showing the areas of increased capacity on the chest X-ray, and here's the CT. And honestly, I read this study, and they asked me, is it COVID? I said, it could be. It doesn't look like it to me. A little more dense consolidation. What are you guys seeing red lines all over the screen, or is that just my screen?
And we're seeing it. We were wondering, is that your
No, someone is doing it, not me. I'm not touching the screen at all.
All right, I've been clearing. As soon as I see it, I push clear. So we'll just let him keep going, and I'll just keep clearing it.
Someone is just drawing things on the screen. I don't know who it is, but anyways, yeah. So this patient was COVID positive, just showing that sometimes you do see slightly atypical patterns. Here's a patient who was feeling fatigue, passed out at IKEA, came in, was afebrile, had some abnormality at the basis, was discharged, was told to isolate at home, came back a few days later with worse consolidation and volume loss, and had this bronchiolar consolidation, not peripheral, very central, and this COVID. So again, multiple varying imaging patterns. What's interesting to note is what happens to this disease and how we're seeing it more in the United States. So what happens is early on, you get these nodules, and over time, these nodules, as the lung tries to heal itself, start to actually grow out, but become somewhat less dense in certain areas. So you can see here the consolidation is less conspicuous centrally, and this thing kind of forms a reverse halo sign. And then these things kind of expand, and if you have multiple nodules, they're sort of kind of can become these conglomerated areas of consolidation and ground glass, like in this patient where, in the lower lobe, you can see some more discrete kind of nodule or ground glass opacities, and in other areas more consolidation. And then the question is, what happens when, and a lot of people who have pneumonia secondary to COVID will progress to this amount of parenchymal abnormality. And the question is, what happens to these patients? And it really depends on multiple factors, which will probably be discussed later, that are beyond me. But we see two people kind of go in two different directions. Again, normally we see patients, the ground glass kind of expands in the extent over a few days. And then as it extends, you start getting this kind of peripheral areas of confluent, either ground glass or consolidation, usually mixed. Sometimes you'll see areas of lobular sparing or subpleural sparing. And this is a pattern of lung organization and healing that we see in numerous pathologies. This is by no means specific for COVID. I mean, we get this in drug toxicity, various infections that can go on for, make a list of 20 things that can give you this pattern. Now, all these patients were COVID, and here are patients with similar disease patterns. This one came in just the other day and was diagnosed as COVID, and he actually has EVALI, which is acute vaping lung injury. This patient had HIV, a little bit atypical, maybe some central lobular nodules here. This was a pneumocystis patient, and this was a prison guard who had really findings that were suggestive of COVID. He had exposure. He worked in prisons with multiple patients that had COVID, but he had 4 or 5 tests, including a bronchoscopic test, which were all negative for COVID on PCR. So what the underlying diagnosis was, we're not sure, but he got better on antibiotics. So what happens, hopefully, is that these peripheral areas, consolidation and ground glass, melt away over time as the patient heals, and hopefully the lung returns to normal. But we know that's not always the case, and a lot of patients progress to more severe lung injury and diffuse alveolar damage, or ARDS. Here's an older patient who returned from a skiing trip, and you can see the classic progression from kind of pneumonia to ARDS, diffuse alveolar damage. Here is his CT showing diffuse ground glass and consolidation. Not a lot of architectural distortion at the time, not a lot of bronchiectasis, but he did develop bursting volume loss, and unfortunately he did pass away. But here's another patient with very, you can see comes in, looks fine, comes in a couple days, it just starts sent home, returns with worsening symptoms. You can see it's starting to develop some hazy opacity in the left lung, and then within 2 days, you can see the dramatic progression. And we're seeing these patients who go downhill very, very quickly, which I'm sure all you guys have seen as well. and findings of pretty severe diffuse alveolar damage. Here is the CT that just looks like any severe multifocal pneumonia that we'll see. And, this patient could easily have gone and like the prior patient died, but he actually recovered. And this is now a few weeks after his discharge. You can see that his lungs are not, here's initial emission where he came in mildly symptomatic, where it looked normal. Here's where he's in very severe failure, respiratory failure with diffuse alveolar damage. And here he is now a few months later. Lungs aren't completely normal, has some areas of parenchymal scarring, but the lungs have organized this theory and healed it and done a good job. So, showing you these cases, and you guys can look and think, which one of these patients have COVID-19, and the answer is none of them have COVID-19. These are all cases of various causes of lung injury leading to a kind of an organizing pneumonia pattern of various etiologies. And then quickly, just to show you guys, this is something we're seeing a lot of and is obviously in the news. Here's a patient with diffuse alveolar damage, again, unknown cause, but this was COVID. And then the reason we're doing a lot of our studies now is to assess for pulmonary embolism, which is, I didn't believe the initial report when they were coming out about the frequency in patients, especially given anticoagulation, but we are seeing it. And for us, it's mostly kind of distal segmental and subsegmental disease. These are all different patients with diffuse alveolar damage and multifocal or multiple pulmonary emboli. Most of the cases we're seeing, again, are segmental or subsegmental. Here's another case. But in the literature, there is a report of larger central PEs. Our cases here we don't have a massive number of cases, at least ones that are undergoing imaging, but we actually have a 33% positive rate, which is right in between. And most papers are showing between a 20% to 30%. Another paper just being published or is in, I think, pre-release, showing up to 45%. So it is, why that's happening, that's beyond me. I'll let you guys figure that out. But these patients are definitely developing pulmonary emboli. And it's not just pulmonary emboli. Here's a patient who was just admitted last week with findings, again, non-specific findings of acute lung injury. And he was transferred to us because he had noticeable discoloration of his foot, and he had large clot in his superior femoral artery, popliteal artery. And so we're seeing arterial thrombosis as well. And here's the young woman with diffuse alveolar damage from COVID who had altered mental status and had a stroke. So we're seeing the vascular side effects from this. So I'm kind of running out of time, but it's kind of a whirlwind tour of the imaging findings, the evolution over time, kind of how some people get better as the injury organizes, others kind of don't do as well and progress to DAD and hopefully survive. And most of our patients here are surviving. And we are seeing a fair amount of vascular issues related to this. And that's it.
That's terrific. That was a whirlwind tour, I have to say. It's sad that we've seen so many cases, but as you said, we've had some pretty good outcomes. And you mentioned the hypercoagulable state in these COVID patients, and we are planning on having a training forum session on that in 2 weeks from now. So late June, we will be dedicating the entire session to try and understanding why we're seeing so many blood clots in these patients. I was just talking to one of the fellows today, and they said when they put in a large triple lumen catheter, the flow back was so sluggish because there were all these sort of micro thrombi. So very interesting. Let's see.
Yeah, no, it is interesting.
We have a comment in the chat. So anybody who has questions for Dr. Kligerman, please post them in the chat. We have one comment that says, at Sinai, we saw a lot of pneumomediastinum post-COVID, seeing a few giant cysts, as well as much larger than pneumatoceles. Have you seen anything like that, Seth?
Yeah, we're seeing pneumothoraces, we're seeing pneumomediastinum. I think we see those things in people with acute lung injuries from all causes. I don't think there's been a study showing that the rate of pneumothorax or pneumomediastinum is any higher in people with acute lung injury from COVID compared to other causes of acute lung injury. Giant cysts we're not seeing in the early stage, but I know they're being reported as secondary to, after the injury resolves. People are sometimes being left with these cystic areas where the parenchyma presumably has been severely injured. I have seen that, but again, I've seen that with cases of EVALI and cases of diffuse alveolar damage from influenza pneumonia and all various causes. So we are seeing that, but I don't think they're specific for COVID lung injury.
Fair enough. I actually personally thought there was so many interesting overlaps, sort of parallels with EVALI, the e-cigarette vaping induced lung injury. And I was actually really glad that that epidemic from 2019 tapered down quite a bit before the COVID pandemic took over.
It's actually popping back up. We've had three cases in the past 2 months here. And I have colleagues, we're writing a big paper on EVALI, and we have colleagues around the country as people are quarantining and sitting home. They have a lot more time to vape and, sit around and do stuff. And we're seeing a resurgence, and every single one usually is misdiagnosed even though they do look different in many instances, they're being misdiagnosed as COVID. And then eventually they get the diagnosis via history and obviously negative PCRs and other things.
Yes, and you kind of hope that they get the history taken correctly of vaping, and that maybe they're one of the 80% that have the GI symptoms to try and tie it to that unique sort of constellation of symptoms. There's one more question in the chat: is thrombus in typical pulmonary embolism patients different from microvascular thrombus and COVID? I don't know if you want to tackle that one.
Well, we don't see microvascular thrombus, and that's something they're seeing on autopsies and other pathologic specimens. But there is no difference in a PE that we're seeing from COVID versus a PE from any other patient. Again, I've seen more distal disease, but the literature out there doesn't support that finding, because the question is, people say, are these emboli or are they in situ thrombus? And, because a lot of people say these distal emboli may be in situ. Again, I don't know if that's true, but I don't think that's the case here, because the majority of patients also have DVTs and other issues as well. But there's no, and again, then there's a lot of patients with big central PEs, and the literature is suggesting that the majority have lobar and proximal segment PEs, but there's no way for us to differentiate. They look all the same.
All right, thank you so much. If you wouldn't mind taking a quick look in the chat box, I think there's a couple of questions that you're probably the best person to tackle. Otherwise, we have some other experts who can jump in as well. So thank you so much for joining us. We really appreciated that presentation. We're going to move on to updates and controversies in COVID care with Dr. Cameron McGuire. He actually did internal medicine residency and his chief residency at the University of Colorado. But prior to that, he did medical school at Tulane and college in Connecticut. We're lucky to have him here at UCSD as one of our stellar pulmonary critical care fellows. And he's going to take us through some of the newest and greatest, and maybe some of the low points in publications as well. Thank you, Cameron.
Thanks a lot, Dr. Crotty Alexander. Can everyone see me and or hear me?
Yes.
Okay, excellent. Last time I joined you all was about 5 weeks ago, and since then the COVID landscape has changed drastically from the perspective of publications. In the past week, there were over 2,500 papers published with the word COVID, coronavirus, or SARS-CoV-2, according to PubMed. And that's actually down from 2 weeks prior, where it hit its peak at over 2,800 in a week. And so if anyone's able to stay completely up to date on those, props to you. But for those of you who are looking for a brief review of the literature published in the past 7 to 10 days, stay tuned for the next few minutes. So first, we'll talk about the publication soap opera that's on everyone's mind. There were 2 major retractions this past week from some of the highest impact factor journals out there. This first published paper, published on May 1st in 2020 in New England Journal, and then this paper published in Lancet on May 22nd, were both retracted in the past week. The soap opera is long, twisting as most soap operas are, but we'll keep this fairly undramatic. On May 30th, the authors of the Lancet published an error. You'll notice the arrow there. And then a few days later, over 200 physicians and scientists signed a petition that they sent to the editors of The Lancet, which was published 4 days later on June 3rd, leading to the retractions of the New England Journal article on the 4th and the Lancet article on the 5th. We won't get into the underlying data abnormalities or the people involved, but suffice it to say that it had and continues to have a lot of ramifications for publications. So in spite of those retractions, I just want to update everyone that hydroxychloroquine still is not a miracle drug. There's no evidence of benefit in any large trials at this point. There is not really significant evidence of harm. The one trial that did point to a lot of harm was one of those retracted trials. However, there is no evidence of benefit, and this is supported by 3 large trials. One was published this week, and that's the one I'm highlighting here by McGuire et al. It was a post-exposure prophylaxis trial. It was actually prospectively done as opposed to the rest of the trials I'll highlight. The N of this trial was 821 patients. They were treated with hydroxychloroquine for 5 days after exposure in either a high-risk or moderate risk setting, which is defined as less than 6 feet away, not wearing a mask, and or not wearing eye shields for at least 10 minutes with a confirmed COVID-positive patient. In May, Rosenberg et al. From New York published a retrospective study. The N of this study was 1,438, showing no benefit to hydroxychloroquine or azithromycin or the combo. That's in sicker patients in the hospital, and it's isolated to multiple New York hospitals. And in April, Magagnoli et al. In the VA system, it was through multiple VA hospitals throughout the US, but in multiple different cities that were heavily hit with COVID and coronavirus in March and April, published a study showing no benefit and possibly a trend towards harm. These are in contrast with the original study published by Gautret and Raoult out of France, where the N was 36 if you're being generous to the author's interpretation of the data, or 42 if you're using an intention to treat analysis. And this retrospective small N study is the only one that we have that shows any benefit. So it is not a miracle drug. It does not have benefit, despite those retractions. Okay, so moving on to other things besides the drama and soap operas that have been playing out. Convalescent plasma. There was a big study published this week in JAMA. It was underwhelming for critically ill patients. Those were defined as patients having a life-threatening illness, defined as needing mechanical ventilation, extracorporeal membranous oxygenation, and then certain criteria of non-invasive ventilation, though those usually were in the severely ill patient category. This is the article I'm referencing. This was published on June 3rd, in addition to that McGuire et al. Article from the prior page, though this one was published in JAMA. Having said that, even though the data were underwhelming for critically ill patients, if you look at a subset of patients, severely ill patients who required supplemental oxygen, high flow blender, and most patients requiring non-invasive ventilation, there actually was a statistically significant benefit in 28-day mortality and duration of hospitalization. So akin to the remdesivir trial, which we talked about last week, published by some of our own here at UCSD, as well as many other across the country, there may be a benefit to starting convalescent plasma in those patients who are severely ill enough to require oxygen, but not critically ill enough to require extracorporeal membrane oxygen or mechanical ventilation. Stay tuned, multiple trials still pending. All right, as we start to ease restrictions and become less socially distant moving forward, I think there are a few things that are important to remember. And these were all published this week as well. Asymptomatic carriers are real and they're common. So Eric Topol and Daniel Oren, who are right across the street here at the Scripps Institute, published this on June 3rd in the Annals of Internal Medicine. They looked at the prevalence of asymptomatic carriers, looking at some of the largest cohorts of populations that we had really good access to the data. So Diamond Princess cruises, the VO population in China, the Iceland cohort, a homeless shelter in Los Angeles, and then a couple of other large outbreaks, including the USS Teddy Roosevelt and the Charles de Gaulle aircraft carrier, among others. And this is what they noticed. Approximately 40 to 45% of SARS-CoV-2 infections confirmed with antibody positivity and or PCR by ELISA. They can transmit the virus to others for an extended period, including longer than 14 days, and 40 to 45% of them were entirely asymptomatic. Less than 3% of those asymptomatic carriers went on to develop symptoms after their potential transmission of the virus. Additionally, the WHO, the World Health Organization, came out with recommendations for masks this week in their interim guidance from the 5th of June, basically saying that anyone who is in a setting where they cannot socially distance, defined as greater than 6 feet or 2 meters in their missive here, though I note that 6 feet and 2 meters are not the same distance, should wear cloth masks at a minimum. We'll talk about differences in masks in a moment. So that is now recommended for anyone who's going to be out and about on the town here in San Diego, over there in Boston, or anywhere else who's tuning in across the world. And believe it or not, masks are beneficial if you look at data, in addition to physical distancing and eye protection. So this was a systematic review and meta-analysis published in The Lancet this week as well, I believe on June 3rd or 4th, where they looked at these 3 different things. They did a multivariate analysis, and they found a dose response of effect for physical distancing. So anyone who was a meter or more away from someone who was positive with coronavirus had less of a likelihood of becoming infected than those who were less than a meter away. And the further you were from someone, the stronger the effect. Face masks also had a strong effect, and the type of mask did matter. So 3-ply masks were better than 2. 2-ply presumably is better than 1-ply, but who uses 1-ply anything? And then N95s were better than all of the above. And then eye protection was significantly better than no eye protection. All right, so those are some of the big updates from the literature this week. I tried to hit mostly the major journals, again, over 2,500 publications. 2 quick additional notes. These are just figures. This one from the CDC, whether you agree with everything they've said over the past 3 months or not, they do have a large set of data that they can mine for trends, and this is a pretty interesting and possibly scary one. So over the course of the COVID-19 pandemic, emergency department visits have declined by 42% across the country. This is during this month of March 29th to April 25th, though they just released this figure a few days ago. That's potentially quite concerning as we start to open back up. Maybe the next surge is not actually the second COVID surge, but it's the surge of all of the patients who stayed away, who typically use the ER as their primary care facility, who are now going to present with tertiary problems of a primary illness. So stay tuned for that. And then the second COVID surge will come when respiratory season arrives. And then last but not least, and I think to echo what Dr. Crotty Alexander mentioned at the beginning of this session, is that race and COVID-19 are inextricably linked. So this is just a screen grab from NPR, but it's actually using multiple different data sources, including CDC data, as well as state departments of health data. And here you'll notice the proportional increase in both cases as well as death rates for people of color, specifically African Americans. They did similar analyses for Hispanic Americans, Native Americans, and then people who consider themselves of mixed or multiple races. You'll notice that in almost every state, the case rate is significantly higher, up to 300% or more, and the death rate significantly higher as well. So as we move forward together in solidarity, I think one of these things that we all need to work really hard on is how to level the playing field in terms of equitable delivery of healthcare as well. And that's all I have this week for controversies and questions in COVID. Feel free to put some questions in the chat, and I'll sort of try to respond by typing as we go, but I don't want to delay the next speakers from starting. Thank you for listening.
Thank you so much, Dr. McGuire. That was perfect. That really covered a lot in a very short period of time, because as you said, the field is moving rapidly, sometimes taking away data, sometimes adding data. So hopefully as we move forward, we'll have stronger data to work from. If anybody has questions for Dr. McGuire or on the recent updates in COVID, please post them in the chat box. Again, we have plenty of people on board who can answer your questions. With that, I'm going to move into our final presentation. I do always warn people that we tend to run over by like 5 or 10 minutes. But we have Dr. Sydney Ramirez here with us today. So she did her MD PhD at University of Texas Galveston before coming to San Diego to do her residency and infectious disease fellowship. She's doing her research training at the La Jolla Institute for Immunology with my big brother. Yay! And we're also very excited to have here with us Dr. Josalyn Cho from the University of Iowa. Josalyn and I were actually classmates together at Massachusetts General Hospital for internal medicine residency and pulmonary critical care training. She stayed on as faculty at Mass General for several years before being recruited to the University of Iowa. And I had the pleasure to hear her give grand rounds on the immune responses and inflammatory changes in COVID. So with that introduction, I'll let Dr. Ramirez take it away and give us some updates on what is known and unknown about the immune responses in COVID. Thank you.
Okay, thank you, Laura. Hopefully you can all hear me. And I don't hope that I have that fax noise or whatever that was in the background. Okay. So some of you might have seen this already. We had a publication in Cell that came out on May 14th, which was a great birthday present for me. It was a joint effort between Alessandro Sette's lab and Shane Crotty's lab, which I've joined. And you can just see kind of a snapshot of the graphical abstract and summary on the side here. So because we work on T cells in both of our labs, the focus is really going to be on the adaptive immune response to COVID for this talk. So major knowledge gaps in the understanding of immunity to SARS-CoV-2. We really don't know much about the adaptive immune response to this particular virus, considering it's such a new agent on the scene. But we do need to know about the adaptive immune response for the sake of vaccine design purposes. It's also important for us to be able to predict herd immunity, what percentage of the population needs to be protected in order to stop the pandemic spread of this virus. And how does that impact social distancing policy? So to what extent do we need to continue to practice social distancing to avoid subsequent waves of the virus? We don't know how long immunological memory to the virus lasts, again, because it's a new agent recently discovered. And we also don't know what kind of immunity is important to protect against COVID-19. So obviously when we're designing vaccines, we want to try and mimic a protective immune response in the absence of natural infection. So it's important to understand what sort of immune response is protective. So one of the questions that we initially sought to answer was, do people even develop immunity to COVID-19? So we do know that in the majority of individuals, it's an acute infection and that most people are able to overcome the infection and have resolution. And so we thought to ask sort of what kind of immunity is important against COVID-19. Is it the B cell response and antibody production? Is it the CD4 helper T cell response, the CD8 cytotoxic T cell response? Is it a combination of all of the above? And again, our labs really focus on the adaptive immune response. So what you're seeing here is, the adaptive immune response specifically. So antibodies, we know that in basically all of the licensed vaccines on the market, we focus on the antibody response, and that's what the vaccines are designed to elicit. But on the immunologic level, we understand that CD4 helper T cells help by actually promoting the correct antibody response. And without them, we really don't get the types of neutralizing antibodies that we know are important for protection. And so if we go back to the original SARS, we see that there is a role for T cells even in the absence of antibody responses, and that it was necessary to both have a T cell response as well as an antibody response to protect mice in the SARS model. And so we also look at cytotoxic T cells, knowing that when it comes to viral infections, classically the cytotoxic T cells are important for killing virally infected cells. There's also some interesting studies where they looked at individuals with A-gamma globulinemia, and they were able to actually survive COVID-19 even though they don't have an appropriate antibody response, implicating the CD8 T cell response as being important for clearing infection as well. So this is a fun model, a Lego model of SARS-CoV-2, just to kind of break things down literally. So we have viral antigens. Typically these are proteins when we're talking about the T cell response. And the T cells respond to these various antigens, and we can see the ones that we really focused on in our manuscript on the right here, S being the spike protein, which is the protein on the outside of the virus that mediates cellular entry via receptor-mediated entry, the M or membrane protein, N, which is the nucleocapsid, which is actually on the inside, bound to the viral genome, and then the non-structural proteins, which again are not part of the outside of the virion, but are expressed when the viruses infect cells. And if we look in the bottom corner, Alex Sete, he was one of our collaborators. He's a co-PI on the project. His lab really focuses on understanding epitope mapping and how CD4 and CD8 T cells recognize these various antigens, what portions of the virus are important for eliciting a robust CD4 and CD8 T cell response. And they actually did a predictive modeling paper where they looked at the original SARS and some other coronaviruses, and they were able to predict sort of which portions of the SARS-CoV-2 virus people would form T cell responses to even before we were able to collect donor samples. So our cell paper really focused on average COVID-19 cases. So we looked at individuals who were not hospitalized, who did not have severe illness, which represents about 80% of the people who get infected. And we looked at a various number of assays looking at how the T cells responded to the viral antigens, and looked at the entire genome, all of the open reading frames, so basically all the proteins encoded by the virus, to try and look at the T cell responses to this particular virus. And so if we look at this next slide, this is specifically looking at the antibody responses to SARS-CoV-2's spike protein. Again, this is the protein on the outside of the virus that mediates entry into cells, and is the protein that's being included in all of the major vaccine platforms, including the Moderna messenger RNA vaccine here in the States, the Oxford vaccine, a number of other vaccine platforms. And we can see here that everyone who was infected with SARS-CoV-2 actually developed an antibody response, and they had not only an IgG response, but as well an IgM and IgA response to the virus spike protein. And then we also looked at cytokine production using what we call AIM assays, and looked at the T cell responses using AIM assays in the lab. So trying to understand, again, how people respond to the virus, but this is kind of in reference to some prior papers. We'll kind of skip that, go straight to SARS-CoV-2 for the sake of time. So if we look at the AIM assays and we look at the COVID-19 infected individuals, we can see that everyone made a CD4 T cell response to the spike protein of the virus, as well as to non-spike proteins of the virus, so the various viral antigens. And this is sort of the total combined response to both spike and non-spike antigens. And the black being the unexposed individuals. So again, showing that these are specific CD4 T cells that were directed against the viral proteins. So just to recap, when we looked at sort of these average COVID-19 cases, so again, people who were not hospitalized, who were able to overcome this infection, we were able to see in 100% of these individuals that they had a CD4 T cell response. 100% of individuals also formed an antibody response, specifically in terms of their IgG response, which is usually the type of antibody that we're looking for when we look at vaccine development and efficacy with immunization. The majority also had an IgA response, about 80%, and this is the type of antibody that's associated with mucosal immunity, which of course is important for a virus that we're saying gets in via droplet, potentially airborne transmission, can get in through the mucous membranes. And this is directed not only against the spike protein, but against other viral antigens. The CD8 T cell response was a little bit more heterogeneous, so not everyone had an obvious CD8 T cell response. About 70% of people developed a CD8 T cell response out of our donors. And then awesome thing, so good news about all of this. Again, the majority of the vaccine platforms are designed to elicit an antibody response against the spike protein. So the good news is we did see everyone formed an IgG response against the spike protein to SARS-CoV-2. We also saw 100% of people had a CD4 T cell response, the CD4 cells being the ones that help promote the correct antibody response. And in general, the fact that we saw, a robust response to this protein is what was anticipated. We thought people would form, immunity of some kind to the virus, specifically to the spike protein, to the membrane protein as well, since it's on the outside, as well as to other viral antigens. So it really, thankfully, matched our expectations. It wasn't, that people did not form an immune response to this virus. We also saw a nice correlation between the IgG titers that individuals had and their CD4 T cell responses when it came to the spike protein. So it seems like these two correlate. If you had a higher IgG titer, you had a more robust immune response on the CD4 side to the spike protein. So again, kind of suggesting that these CD4 T cells are helping to create this antibody response or generate this antibody response in response to the spike protein. And this is just to show that, again, even though we are looking at the spike protein, we really care about this because it's what's included in the majority of vaccine platforms. Everyone, if you see the dotted line, we can see that all of these COVID-exposed individuals formed antibody responses that were significant if they're above this dotted line, and we can see it's to multiple viral proteins. And so we see the membrane protein, the nucleocapsid protein, spike, and then a lot of the non-structural proteins as well generated specific CD4 T cell responses in these individuals. This is sort of an overlay of the genome on the top, just showing the very large single-sense positive stranded RNA genome with the open reading frames that encode the non-structural proteins 1 through 11. This should actually say 12 through 16. Apparently that's a typo. And then the structural proteins that are on the outside of the virus, as well as the accessory proteins, which we can see here. Again, just illustrating that across the genome, we see CD4 T cell responses to various parts of the genome in these individuals, not just to the spike protein, which is shown here. And another really interesting thing that came out of this study that we really didn't expect to see, and that we, sort of did a double take when it came to the findings and double check, triple check to make sure that this was true, we actually saw that people who had not been exposed to SARS-CoV-2 also had some cross-reactivity to SARS-CoV-2. So these are individuals who had their blood samples collected between 2015 and 2018, so well before the pandemic. They had never been exposed to this virus before. And we saw in about half of these individuals, they had a specific T cell response, CD4 T cell response to SARS-CoV-2. About 20 of them had a specific CD8 T cell response to SARS-CoV-2. So the speculation being that these individuals, having been exposed to the common cold coronaviruses that circulate annually, worldwide, that by being exposed to these common cold coronaviruses, they actually were able to form T cell responses to sort of some conserved regions of the genome in SARS-CoV-2 that look similar to these common cold coronaviruses. I'm sorry. There are more slides. I just didn't want to go over time, but I'll let you know that it's a very large group working on this. These are just some of the individuals who worked on the initial manuscript. There's many more individuals who are working on further studies as we move forward. Shane Crotty being the PI whose lab I work in, Alessandro Sette, the other PI who was the co-PI on this project. Aldo's actually the first author on the manuscript. There's a number of people who contributed to this work and were able to get it out quite quickly given the rush for publication nowadays. And there's a number of studies that we're continuing to work on. So, part of what we wanted to look at is, now that we know that there are these T cell responses to SARS-CoV-2, even in unexposed individuals, how can we work with vaccine developers to make sure that they're really looking at the T cell responses in people pre and post immunization? Because the concern being, if people already have these potential cross-reactive T cells, do they also have antibodies? Since the CD4 T cells help make antibodies, and will there be some confusion where if they only look at people post-immunization, they say, wow, that's a really, robust antibody titer to this vaccine, but in reality, will some of those antibodies be pre-existing antibodies that were already there because of prior exposure to common cold coronaviruses? So, that was something that we were concerned about. We've been reaching out to the vaccine developers about that. Epitope mapping, again, the Sette lab, that's sort of their expertise, and it's something that they continue to do, and they're trying to really nail down specifically which portions of the virus both unexposed individuals are having reactions to, as well as those who have overcome COVID-19 or now convalescent have formed memory responses to. And in order to do that, they really need a large volume of blood from donors. So it's one of those challenges where you need people to not only get infected, but recover and be well enough and symptom-free and able to donate a large volume of blood in order to do those studies. And we've had amazing responses from the community, from people who have overcome this infection and who are willing to share with us their precious blood so that we're able to do these studies, thankfully. Very thankful for all of them and their dedication to moving science forward and to helping others to not get this infection. We're also looking at the immune responses in COVID-19 across the spectrum of disease severity. So looking at those who are acutely ill, hospitalized, critically ill in the ICU, less severely ill, maybe in an IMU level of care on non-rebreathers or non-invasive ventilation, looking at those who just require supplemental oxygen, looking at those who are across the spectrum of disease and trying to understand why some individuals get so incredibly ill and others don't, why some are able to recover and others are not. We're also looking into next generation vaccine designs, again, considering the fact that people make antibody and T-cell responses, not just to the spike protein, but to multiple antigens. And so the thought being, if we really want to mimic natural infection and immunity, that we should try and include these other antigens in the vaccine platforms, because we might get a better mimic of what happens in those who are able to recover if we include multiple antigens and don't just focus on the spike protein. And there's a number of other slides that I don't think we'll have time for. I think we're already past 6 p.m., so if anyone has questions, if there's anything that we can discuss.
Awesome. Thank you so much, Dr. Ramirez. You really did cover a lot, and so I really appreciate that. The immune system is so complex and there's so many factors at play, but it sounds like a couple of the key takeaways are that in everybody that you tested that had COVID, they all developed CD4 T-cell responses. And that kind of ties in with the fact that anybody who had CD4 T-cell responses, you also saw development of IgG antibody responses. And so we're hopeful that that's going to be protective in the end. But I wanted to give Dr. Josalyn Cho a chance to chime in. Again, we usually run over to about 6:10, 6:15. We've had some great chats in the chat box, so please check that out for some of the questions and answers going on. But Dr. Cho, do you have any comments?
I just wanted to compliment Dr. Ramirez on really a great talk and important and exciting work. I think one of the things about research in this field is that it tends to raise more questions oftentimes than it answers. And I think your question and some of what Sydney talked about bring up an important distinction between generating an immune response and having a protective immune response. And so it's great that we can measure IgG and IgA, but whether those are actually neutralizing antibodies or will mediate protection from subsequent infections, I think is an important question. And similarly, again, it's reassuring that we see a T-cell response to this virus, but if you look at other viruses, so influenza, for example, we know it's a really specific subset of T cells that lives in the lung following infection that really mediates protection when someone gets re-exposed to the virus. And so I think I'm excited to see where this group goes, and I'm interested to know whether you guys are thinking about doing longitudinal studies to look at how these responses change over time. I think the studies looking at patients who have severe illness are really interesting, and I'd be interested to hear, Sydney, if you have predictions about whether you think they will have more robust or less robust adaptive responses to the virus.
And Sydney, we're actually collaborating on a couple studies here at UCSD where we're drawing blood from the severely ill and looking at the immune response basically every other day over like 14 days. So Sydney's heavily involved in that, and hopefully trying to see how the immune responses in these critically ill patients might be different than those who don't develop the severe form. We're also taking blood from the unfortunate cases that do pass away to see if maybe that was a difference as well, that they just didn't generate an immune response similar to others. Sydney, do you want to jump in? I think you're on mute. There we go.
Sorry. My phone cut out on me, and so I had to join with the computer audio. So we have a number of different studies going on. We're collaborating with a number of groups. So as Laura mentioned, we are working with groups that are doing longitudinal studies. We've got a number of acute donors that we've enrolled at various time points in illness, and we've tried to get multiple time point blood draws from them, but we're somewhat limited by how sick individuals are and how much we can realistically ask them for while they're hospitalized and in the acute phase before they've fully recovered. But we've got a group at UNC, Ralph Barrick's group, they're helping us out with the neutralization assays using wild type virus that has actually just had a luciferase or another reporter gene inserted in there. So we're working with them on that. There's another group at UNC that's looking at even more ELISAs, and we're really digging down into what common cold coronaviruses people were exposed to in the past and to what extent that really impacts their cross-reactive T cell responses. So lots of different things going on. At this point, too early to say exactly what protective immunity looks like, what an appropriate immune response looks like versus an inappropriate immune response. But hopefully soon we'll have some more data out there for everyone to see. It's really a much more heterogeneous group of patients and immune responses when you try and look at people across the spectrum of illness versus just focusing on those who had sort of the 80%, of the disease course where they really didn't get hospitalized, did well, and, presumably made an appropriate immune response. And in those people, we really saw, the classical Th1 response that we would expect for viral infection. So more to come.
Awesome. Anything else, Dr. Cho?
Not off the top of my head. I mean, I think it would be really interesting to look and see, there's also been speculation because there are some reports that patients in the ICU get very high antibody titers, and they don't necessarily correlate with viral clearance. And so there are some questions about whether you could potentially generate, for example, a low affinity antibody response that ends up being harmful as opposed to protective. So I think it'll be really important, as you said, to look at some of the other patient cohorts and see what's happening in those folks.
Yeah,
Fascinating.
Point.
Sorry, Sydney, go ahead.
I know I was just going to throw out for SARS and MERS, there was some data, especially for MERS, that people who had more severe illness generated higher antibody titers, but that they did it later on in infection. And so it seemed as though they cleared the virus later, probably because of a delayed antibody response. And you're right, it's not just about the amount of antibody, it's how good it is. Are these neutralizing antibodies, or are these just sort of non-specific antibodies that don't really prevent the virus from getting into cells? And I think we'll hopefully get that information as we work with the Barrick lab on our neutralizing assays.
Great. Awesome. Well, thank you so much, everybody, for joining. We have 140 people still here hanging in there to hear every last word about these immune responses. Please do click on the feedback form before you leave. We'd love to hear your thoughts. We do try and design each episode to target learners' needs. So if there's something more that you want from the forums, we can still add stuff to next week and the week after. As I mentioned, we do have one coming up about prothrombotic states in COVID. And the first one in July will be about healthcare professional well-being in the time of COVID and things that you can do to that regard. So thank you again, everybody, for joining. It was a really great session. Really appreciated all of our powerhouse presenters for joining us today. So take care, everyone, and good night.